Hi everyone, welcome to our module on disorders of dermal appendages. In this video, we're going to focus on the disorders of skin appendages. Whenever we say appendages, we are referring to structures like hair follicles, sebaceous glands, sweat glands, and nails. So now this might sound like a simple topic, but clinically, this is extremely important because many common dermatological conditions, especially acne and hair disorders, all of them originate from these structures. So what we're going to do is build this step by step, starting from the basic anatomy, then we'll move into disease mechanisms, and finally connect everything to treatment. And that's exactly how the questions are asked and tested in the examinations. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its continued development, you can do so with the link that is on the screen, and that's also pinned in the description. You can contribute to us with any of these payment methods. Now, let's first understand what skin appendages actually are. The skin is not just a flat surface, it has multiple specialized structures embedded within it. So, these includes hair follicles, which are responsible for hair growth, sebaceous glands, which produce oil, and sweat glands, which help in temperature regulation, and nails, which are actually modified keratin structures. Now, here's the important clinical insight. So, these appendages are not isolated. They are all of these appendages are functionally connected. For example, the hair follicle and sebaceous gland together form what we call as the pilosebaceous unit, which is the central structure that is involved in acne. So, sebaceous gland along with the hair follicle forms the pilosebaceous unit. Also, these structures often reflect the internal disease. For example, whenever there is a nail change, whenever there are nail changes, that can indicate a systemic illness, and hair loss patterns can help us point to a particular hormonal or autoimmune cause. So we always need to think that these reflect systemic disease. These are not cosmetic. These are diagnostic tools for systemic disease. Now we move on to one of the most common dermatological conditions, acne vulgaris. Acne is not just a cosmetic issue, it's actually a disease of the pilosebaceous unit, meaning the hair follicle and the associated sebaceous gland. It is most commonly seen in adolescents, and the reason is hormonal, specifically androgen, so it's androgen driven. These hormones stimulate the sebaceous glands to produce more and more oil. Clinically, acne presents in different forms depending on the severity. You may see comedones, which are the earliest lesions, then inflammatory lesions like papules and pustules, and in severe cases, there may be nodules and cysts. So already we are seeing a progression from non-inflammatory to inflammatory disease. That progression is extremely important for both understanding and treating this condition. So, this slide is one of the most important in the entire topic. Acne develops due to four key mechanisms, and every single treatment targets one or more of these mechanisms. So, now let's try to go step by step. First, there is increased sebum production. This is driven by androgens, which stimulate sebaceous glands to produce excess oil. Secondly, there is follicular hyperkeratinization. Normally, the skin cells shed smoothly, but here they accumulate and then block the follicle, forming a keratin plug. Third is the bacterial colonization. The blocked follicle creates an ideal environment for a bacterium called Cutibacterium acne to grow. And fourth is the inflammation. The immune system reacts to this bacterial growth and trapped material, and then finally leads to redness, swelling, and pus formation. Acne is not caused by just one factor. It is a multifactorial disease like increased sebum production, follicular hyperkeratinization, bacterial colonization, and inflammation, all of them contributing to the progression of acne. And that's exactly why combination therapy is used in the treatment of acne. Now let's zoom into what actually forms the earliest acne lesion, the comedone. Sebum is the only substance, or sebum is the oily substance that is produced by the sebaceous glands. It normally helps lubricate and protect the skin. But when it is overproduced, especially under the influence of androgens, it starts accumulating inside the follicle. At the same time, because of abnormal keratinization, the dead skin cells don't shed properly and they just accumulate, forming debris. And this keratin debris, along with the excess oil, forms a plug. So this leads to two types of comedones eventually. Closed comedones or whiteheads, and these occur when the follicle opening is blocked. So the keratin material stays inside, it's covered by skin, and it appears white. Closed comedone appears white, whereas an open comedone or blackheads occur when the follicle is open. The black color in open comedones is not just dirt, it's due to the oxidization of keratin and lipids. So that's a classic exam trick. So students often think blackheads are due to dirt, but it's actually due to oxidation of keratin. So at this stage, acne is still not inflammatory. Inflammation comes later when bacteria and immune response kick in. Now that we understand how acne forms, the next step is to grade its severity because the treatment depends entirely on this severity pattern. We need to think of acne as a spectrum. At one end, you have a purely inflammatory lesion, and at the other end, you have purely non-inflammatory lesions. So we can classify acne into four grades. Grade one is purely comedonal, just blackheads and whiteheads. There is no any kind of inflammation. Grade two produces inflammation. Now we start seeing small red bumps and a few pustules on the skin. Grade 3 is more intense and moderate inflammation is seen with multiple papules and pustules, whereas grade 4 is severe disease with nodules and cysts which go deep into the skin and can lead to permanent scarring. So, so as the severity increases, the treatment becomes more aggressive and more systemic. Now let's try to break down the early stages. In grade 1 acne, the problem is only follicular plugging, so there's no significant inflammation yet. So the goal of treatment is to normalize the skin cell turnover. So that's why we use topical retinoids. These drugs help prevent the formation of new comedones by improving keratinocyte turnover. Now, in grade 2, inflammation begins. So now just fixing keratinization is not enough. We need to target bacteria and inflammation as well. So we add topical antibiotics and benzoyl peroxide. Benzoyl peroxide is especially important as it reduces the bacterial load and also prevents antibiotic resistance. So one mechanism is treated with one drug, and when there are multiple mechanisms acting together, we need to give a combination therapy. Now we move to grade 3, where inflammation becomes more important. At this stage, topical therapy alone is not sufficient because the inflammation is deeper and is more widespread. So we introduce oral antibiotics. So drugs like doxycycline and minocycline are commonly used in this grade 3 acne. Now, these antibiotics are not just killing bacteria, they're also anti-inflammatory. They reduce the cytokine production and helps control the immune response. So in grade 3 acne, we are targeting inflammation due to bacteria and still continuing topical therapy to control the keratinization. So this is a multi-layered approach that we have discussed about. Grade 4 is the most severe form, the nodulocystic acne. So these are deep, painful lesions that can destroy the skin architecture and can lead to permanent scarring. So at this stage, we use a very powerful drug. It's oral isotretinoin. So let's just try to understand why this oral tretinoin is so effective. So it's because it targets all the four mechanisms of acne at once. So this oral isotretinoin targets all the four mechanisms of acne formation at once. It reduces sebum production, normalizes keratinization, decreases bacterial growth, and also reduces inflammation. That's why it's considered as a definitive therapy. So, but because it is so powerful, it comes with serious side effects like teratogenicity. Isotretinoin is one of the most common drugs that you will be encountering in dermatology. So let's try to break it down properly. So mechanistically, it reduces the size and activity of the sebaceous glands, in turn leading to reduced sebum production, which drastically lowers oil production. Without sebum, bacteria cannot thrive, and so there is reduced bacteria and also reduced inflammation. It normalizes the follicular turnover and reduces inflammation. So now let's try to understand the most important point. This drug is highly teratogenic. This means that it can cause severe birth defects if taken during pregnancy. So before starting isotretinoin, pregnancy testing is mandatory and strict contraception is advised. In addition, we monitor lipid levels and uh, also do the liver function tests. Patients also commonly experience dry skin, dry lips, and mucosal dryness. So, isotretinoin is extremely effective, but it requires strict monitoring and caution. Now, let's talk about rosacea. Rosacea is a chronic inflammatory skin condition of the face, but unlike acne, it is not primarily a mechanism of the pilosebaceous unit. It typically affects middle-aged adults, especially individuals with fair skin. The hallmark is facial flushing. Patients often complain of redness that comes and goes initially and later becomes persistent. Over time, we also start seeing inflammatory lesions like papules and pustules, along with visible dilated blood vessels, which we call as telangiectasia. So, at first glance, this can look like acne, but the underlying mechanism and key features are finally very different. So this comparison between rosacea and acne is a very important comparison. No, in acne, the central issue is follicular blockage and increased sebum production. So we'll always see comedones at the initial presentation. It can be either blackheads or whiteheads. In rosacea, these comedones are absent. Uh, Rosacea is more about vascular instability and inflammation rather than just follicular plugging, whereas acne is common in adults and rosacea is typically affecting the acne is more common in adolescents and rosacea is typical in adults. So whenever we see a question describing a middle-aged person with facial redness, visible blood vessels, and absence of comedones, we need to think about a possibility of rosacea very immediately. So if there are comedones, we need to understand that it can be acne. If there are no comedones, we need to uh, consider the possibility of rosacea. So now let's try to build the clinical picture of rosacea. Patients usually present with persistent redness over the central face, especially the nose, cheeks, and the forehead. They may also complain of burning or stinging sensation. Over time, these inflammatory lesions like papules and pustules might appear, but again, without comedones. So that's the key point, without comedones. Another important feature is telangiectasia. These are dilated superficial blood vessels that become visible on the skin. So overall, when you think of rosacea, it's nothing but chronic facial redness with vascular changes with inflammation. If rosacea progresses, it can lead to some very characteristic complications. So one of those complications is rhinophyma. So it's the most classic complication of rosacea. So this is nothing but thickening of skin over the nose, leading to bulbous appearance. It occurs due to chronic inflammation and tissue overgrowth. Another important complication is ocular rosacea. Patients might develop dryness, irritation, conjunctivitis, and blepharitis, which is also called as the inflammation of the iris. So this is important because it can affect vision if left untreated and severe condition. So rosacea is not just a cosmetic illness; it can have functional consequences as well, like in ocular rosacea. The management focuses on controlling inflammation and avoiding triggers. Topical treatments like metronidazole are commonly used. In more severe cases, oral antibiotics such as doxycycline are given. These are not just for antibacterial action, but they are for their anti-inflammatory effects. For vascular features like telangiectasia, laser therapy can be extremely helpful, and in advanced rhinophyma, surgical correction may be required. Uh, Equally important, along with laser therapy and surgical correction, is the lifestyle modification. Patients should avoid triggers such as alcohol, spicy foods, and heat and sun exposure because all these things can worsen flushing. So treatment is both medical and behavioral in rosacea. Before we talk about hair loss, we must understand about how the normal hair grows. Hair growth occurs in a cycle in three phases. First is the anagen phase. This is where the hair is continuously growing, and most of our hair, around 90%, is in this phase at any given time. So, second is the catagen phase. This is a short transition phase where the growth stops and the hair follicle begins to shrink. Third is the telogen phase, which is the resting phase. Eventually, the hair is shed from the follicle. Hair loss occurs when this cycle of anagen, catagen, and telogen is disrupted. So, for example, if too many hairs shift prematurely into the resting phase, we can get excessive shedding. Hair loss can be broadly classified into two types. First is non-scarring alopecia. In this type, the hair follicles are still intact. That means hair loss is potentially reversible. Second one is scarring alopecia. Here, the hair follicles are destroyed and are replaced by fibrotic tissue, as in this image. So this leads to permanent hair loss. For exam purposes, most questions focus on non-scarring alopecia because these conditions have distinct clinical patterns that we may be able to recognize. So whenever you see a question on hair loss, the first step to do is to understand are the hair follicles preserved or destroyed. Androgenetic alopecia is the most common form of hair loss. It is driven by androgens, particularly a metabolite which is called as dihydrotestosterone. So, and this DHT causes progressive miniaturization of the hair follicles. Over time, thick terminal hairs become thin and fine hairs. So, this pattern of hair loss is very characteristic. In males, you can see recession at the temples and thinning at the crown. This creates a characteristic M-shaped pattern, as you can see in this image. In females, hair loss is more diffuse over the crown, but the frontal hairline is usually preserved. So, whenever a question is tested on androgenetic alopecia, pattern recognition is the key. This is a very important condition because it often appears in clinical scenarios. So, telogen effluvium is a type of diffuse hair shedding that occurs after physiological stress. So, common triggers could include surgery, childbirth, severe illness, and rapid weight loss. So, after the stress event, a large number of hairs prematurely enter the telogen phase, but the hair doesn't fall out immediately. So, there is a delay for about 2 to 3 months before shedding occurs. So, that delay is a classic exam clue. Whenever a question mentions hair loss 2 to 3 months after extremely stressful day-to-day life, you need to think about a possibility of telogen effluvium. So, if a patient reports their hair loss a few months after a stressful event, we need to think about telogen effluvium. So, whenever there's diffuse shedding with time delay, it's telogen effluvium. So, this is a very key point. Alopecia areata is an autoimmune condition. So, yeah, the immune system targets the hair follicles, leading to sudden, well-defined patches of hair loss. So, the affected areas are usually smooth without any scaling or inflammation. One of the most important diagnostic clues is the presence of exclamation point hairs. So, these hairs that are narrower at the base and wider at the top, giving them characteristic appearance. So the classic presentation in alopecia areata is sudden patchy hair loss with smooth skin and exclamation hairs. Exclamation point hairs is nothing but a wide top and a narrow base. Now let's start with a very practical condition that's pseudofolliculitis barbae. This occurs due to the way hair grows after shaving. So, in individuals with curly or coarse hair, when the hair is cut, it can curve back and re-enter the skin instead of growing outwards. So, this can trigger an inflammatory reaction. Clinically, these patients present with small, painful bumps or blisters along the beard area, especially at the jawline. So, this is often there is often itching and irritation. present in this condition. So this is not an infection, it is a mechanical problem that's leading to inflammation. So hair re-enters the skin, leading to inflammation, leading to papules and pustules. Now we move into nails, which are an extremely important clinical topic. Nails are not just cosmetic, they can provide clues about systemic disease. So when examining nails, we always need to think systematically. So first we need to look at the shape, then the surface and the color, and then how the nail is attached to the nail bed. Different abnormalities can point towards different conditions. Nail examination is essentially a diagnostic tool that can give you information about what's happening inside the body. Let's go through some of the high yield nail findings. First is the nail pitting. So these are small depressions on the nail surface. These are classically seen in psoriasis and also in alopecia areata. Next is koilonychia, which means spoon-shaped nails. This is strongly associated with iron deficiency anemia. Then we have splinter hemorrhages. These are thin longitudinal reddish or brownish lines under the nail. They can be seen in infective endocarditis but can also occur with trauma. So each of these findings is a clue that's pointing towards an underlying condition. Continuing with the nail findings, view lines are transverse grooves across the nail. So these indicate a temporary interruption of nail growth, usually due to severe illness or chemotherapy. Onycholysis refers to separation of the nail from the nail bed. It is commonly seen in conditions like psoriasis and hyperthyroidism. And finally, let's discuss about clubbing. So this is characterized by loss of the normal angle between the nail and the nail bed. So that angle is also called as the Lowy bond angle. So whenever this angle is greater than 180 degrees, you need to think about possibility of clubbing. Clubbing is associated with chronic hypoxia, especially in lung diseases and also in congenital heart disease. So nails are essentially very important and helpful systemic clues. Now let's just quickly try to bring everything together and summarize this module. Acne is driven by four mechanisms like sebum, increased sebum production, increased keratinization, bacterial proliferation, and inflammation. Severe acne, grade 4 acne, is treated with isotretinoin, which requires careful monitoring because of its side effects like teratogenicity. Rosacea can look like acne, but the key difference is the absence of comedones. In hair disorders, pattern recognition is the clue. So, androgenetic alopecia shows patterned hair loss, whereas telogen effluvium has a delay after stress, and alopecia areata is autoimmune with patchy loss and soft skin. Nail findings act as windows into systemic disease, so each pattern tells us something specific. So the overall strategy in this uh, disorders of developmental appendages is that we need to recognize patterns and then link them to mechanisms and then apply that to clinical scenarios. So that's how we solve dermatology questions properly. I hope you like this video. I would like to come back very soon with the third video of a dermatology series. Till then, bye.